Hello, and thank you for joining this Neurology Live peer exchange discussion entitled New Paradigms, Preventative Treatment for Chronic Migraine. We'd like to talk about recent understanding of migraine pathophysiology, which has led us to the development of new novel treatment approaches for chronic migraine. In this Neurology Live peer exchange, I am joined by a panel of experts in headache medicine. We'll discuss the latest information available on preventative therapies for migraine, including practical strategies for using CGRP-targeted monoclonal antibodies. I am Dr. Steven Silberstein, Professor of Neurology and Director of the Jefferson Headache Center at Thomas Jefferson University in Philadelphia. I am also Editor-in-Chief of Neurology Live. Participating today are friends and colleagues, all experts in headache medicine, which include Dr. Andrew Blumenfeld, Director of the Headache Center, Southern California, San Diego, California, Dr. Deborah Freeman, Professor of the Department of Neurology and Neurotherapeutics, and the Department of Ophthalmology at the University of Texas Southwestern Medical Center in Dallas, Texas. Dr. Stephanie J. Nahas, Associate Professor at the Department of Neurology at Thomas Jefferson University in Philadelphia, Pennsylvania, and Director of the Headache Medicine Fellowship Program at Jefferson Headache Center. She's also Assistant Director of the Neurology Residency Program at Thomas Jefferson University. And Dr. Stuart Tepper, Professor of Neurology at the Geisel School of Medicine at Dartmouth and Hanover, New Hampshire. Thank you for joining us, and let's begin. The first segment, we're going to be talking about treatment algorithms for migraine preventative therapy. Let's talk historically about it and all chime in. How long have we been treating migraine preventatively? Well, we've been doing it for ages. You can read Shakespeare, you can read Plato, you can read the papyrus in ancient Egypt, but the modern treatment of headache began in this century. And most of the drugs that we use for the treatment of migraine have been discovered by accident to be effective for migraine. For example, beta blockers were given to patients with hypertension and their migraines went away. Antidepressants were given to patients with depression and their migraines went away. So almost all of the drugs we've had until recently were developed for another reason, another cause, and were found by accident to be effective for the treatment of migraine. And do you have any comments or questions or
I think this is true, this serendipitous approach, because I think there's a lot of comorbidity with migraine. And so migraine patients often have epilepsy, so they might have been on an anticonvulsant to treat their seizures and inadvertently found that their migraines improved. Similarly, migraine patients often have hypertension, a lot of vascular risk factors, and so that's where the blood pressure medicines stem from. And we also know that depression and anxiety are very common in migraine, particularly chronic migraine. And there's this overlap, and that this led to the serendipitous discovery that you were talking about.
Stephanie, I'm going to go over there and I'm going to come back. What have you seen in your own patients in terms of how preventative medication reduces frequency, duration, or severity?
Well, certainly that's what we're going for, to reduce the disease burden, reduce the disability associated with attacks, make them fewer and farther between, less intense. That doesn't always happen, unfortunately. I might say it's more common than not that the first thing I start on someone, they have to try something else. And you have to be patient and have a high tolerance for frustration for this reason. And this is something that I think is important to say up front when you're taking care of patients with migraine.
I think it's important to state how futile the old preventive medicines have been in terms of usage. And there was a study by HEP in 2015 that was a very large database that was evaluated, and we're talking about chronic migraine, and in patients placed on conventional oral prophylaxis at the beginning of a year, over 83% of those patients had discontinued the use of those preventive medicines by the end of the year. And in Andy's international burden of, what was the international burden of migraine study?
Correct. Steve.
The two most common reasons, not surprisingly, that they discontinued were side effects and lack of efficacy. So the responder rates for our old preventive medicines, in the best of situations, 45% of patients would get at least a 50% reduction in their migraine frequency. And I think that that was the place from which we began in the last year to see the change. I think that was where we were.
What have you seen in your own patients regarding how current preventives affect frequency, intensity, and duration of attacks?
Well, certainly that's the goal of preventive treatment, to reduce the burden of disease, make the attacks fewer and farther between, less intense, more responsive to acute treatment. But that doesn't always happen. Unfortunately, more often than not, the first medication that I might try on somebody doesn't work. And you need time to establish whether it's effective or not. For that matter, most patients seeing me have tried many things already. So it can be very frustrating. And in order to achieve success, you have to have perseverance in patience, knowing that it can take weeks or even months to establish whether the treatment is effective or not. And you may have to move on to something else. So having a high frustration tolerance is important. And stating that up front so the patient understands that this is what we're in for is also important.